Hello, welcome to the joint venture sports medicine podcast by Smith+Nephew. My name is Emilio Calvo. I'm based in Madrid. I'm focusing in shoulder surgery, and I'm working in a academic hospital in Spain, in Madrid. And it's my real pleasure to introduce you Dr. Pascal Boileau. Professor Pascal Boileau doesn't need an introduction. He's been based in Nice for many years, and he's one of the masters that has contributed for the most to shoulder surgery. So thank you, Pascal, for being here with us. And we'll try to focus in this podcast to the treatment of shoulder instability, including the wide range of different scenarios we find in shoulder instability. So if we try to analyze what has been going in shoulder instability along the years, what has been your evolution in the approach of patients with shoulder instability in the last years?
Initially, the big revolution was arthroscopy, because arthroscopy helped us to discover many pathologies that we didn't know before, like of course the Bankart lesion, we knew that, but the Hagel lesion and all these different intra-articular lesions. So the arthroscope was a nice tool to discover the pathology of recurrent anterior instability. And then we have many progress, and including new way of fixation of the tissue with suture, anchors, and other things.
Well, fixation has been a big change. I remember the early days when we tried to do soft tissue repairs with the old anchors. They were difficult to manage. Now things have been much easier now. What do you think is the role today of the knotless anchors? Because we started doing anchors that required to be knotted. Do you think there's a big difference using knotless anchor compared to the former anchors?
I think initially I was not really for the knotless anchors, because the amount of tissue that you were taking with the early design was too small. You could fix the labrum, but you could not do at that time a capsular shift together with the labrum repair. But today I think there have been many progresses, and I think some of these knotless anchors are good. And anyway, I mean, some surgeons have difficulties to tie knots, so we have to go in this direction anyway.
Because I remember the days when we used to insert these sometimes big anchors. I remember the metallic anchors as well, and the metallic solid anchors. How all suture angle has changed your practice?
I mean, one of the major progress, I think, is soft anchor. I mean, all suture anchors, because we have seen some catastrophic arthritis related to prominent either metallic or PIC anchors. So I think inside the glenohumeral joint, it's good to use, at least for me, soft anchor. So
this is your preference for treating soft tissue problem, using all suture anchors or soft anchors?
Yeah.
I'm doing the same. I try to avoid complications related to PIC or even to resorbable anchors. I don't see any problem, as has been reported, with osteolysis around the anchor. This is not a major issue to me.
No.
I feel quite confident using these anchors. So you think that these anchors represent really an advantage for patients as well?
Yeah, of course. I think it's a real progress, a real advantage.
Let's go to another interesting topic. Is that I've been trying to analyze and report the results of my practice treating patients with on shoulder stability. And remember when I started doing a shoulder arthroscopy that in those days the gold standard was the Bankart repair. I'm not French, sorry, but the gold standard was the Bankart repair. And I could say that the majority of my patients, unless they had a huge bony lesion, was indication for a Bankart repair. I felt very confident in the beginning. I felt very happy, but when you follow this patient, you realize that they fail.
I did the same path. I followed the same path. When I came back from USA after my 2 fellowships, I was convinced that the Bankart was the best operation.
Yeah, I was doing only Bankart repair. I think that the latter was a French crazy idea that was only used in France. And in the beginning, when you see this patient that have been operating using a conventional Bankart repair, patients are happy, you are very happy, but you follow these patients, you notice that they begin to fail, and it's not the only solution. So
not only to fail, but to stop doing sports.
Yeah, that's also very important.
Because We evaluate, we assess our results with recurrence of instability. But beside recurrence of instability, you may have a persistent anterior apprehension,
Absolutely.
pain, and different symptoms that, and feeling the shoulder not strong enough to continue to go back to sports like collision or contact sports.
Yeah, that's interesting because we could see that the recurrence rate could be high, but many of these patients didn't want to be revised because they felt their shoulder stable enough, but they quit practicing the sports, and this is a major limitation.
Exactly.
This is a major limitation. So in those days, I remember we were trying, both of us, trying to assess how important was the piece of bone that was missing in the joint. And your friend, so you moved quicker to the lateral than I did. But we all realized that the bone block procedures were to play an important role.
So does it mean that you think that the on-track, off-track concept is very important?
That's a different story. We'll talk about it later on. I think it's important. I think it does make sense. It does make sense, the concept of off-track. It's very important to understand the dynamic interplay between the glenoid defect and the Hill-Sachs defect. But going back to the beginning, I'm talking about my practice now. I started doing bone block procedures in patients with more than 20% of glenoid bone loss. That's huge. That's huge. 20%. Yeah, but patients with smaller bony defects at the glenoid and with Hill-Sachs defect also failed.
Yeah.
So what is your practice today to manage patients with a small, I would say, subcritical bone defect? Is this indication for a bony pancart or for a bony procedure, or?
So first of all, if we talk about the Latarjet, we should not speak about bony procedure. As you know, the Latarjet procedure, 70% of the efficiency of the procedure is
coming from the sling effect.
Is a sling effect.
Correct.
So I think it's a mistake to continue to speak about bone block procedure for the Latarjet. For iliac crest bone graft, for tibial allograft, okay, it's pure bone block. But the Latarjet is more than this, and that's the beauty of this procedure.
Absolutely.
So going back to your question, I think that, of course, the concept of on-track, off-track forces us to think about the combination of the bone loss. Anterior for the glenoid, posterior for the humeral Hill-Sachs lesion. And I think that speaking only about 10%, for instance, of glenoid bone loss doesn't mean anything to me, because there is one thing that we are not able to do. It is to measure the elongation of the capsule and the ligament anteriorly. So you may have, for instance, no bone loss or small bone loss, and still you need a Latarjet procedure to stabilize this shoulder because of the extreme hyperlaxity of this shoulder. So for me, my evolution has been to do bankart for many times with capsular shift, going far down, 6 o'clock, 7 o'clock.
Trying to do vertical plication.
Because you go back to USA and they were telling you, oh, you don't have the good clubs. Okay, maybe I'm not a good surgeon, but my patients have recurrences. So we start to do everything we could, you and me.
Yeah, I did the same.
To shift the soft tissue. Then, Gene Wolfe came in this, and he proposed to do a Hill-Sachs remplissage. And
that was completely new. That was disruptive.
At that time, I was thinking, this guy is crazy.
I thought the same. This is not going to work. It's going to produce some shoulder stiffness. That was my feeling.
But after 1 year, I said, I should try. He's honest. He reported his results, his technique.
Correct.
So I did a series of bankart plus Hill-Sachs remplissage. It was a little better, but still not perfect. And then the evolution has been to try to develop the arthroscopic Latarjet.
Yeah, I think you did a great job trying to develop the technique for arthroscopic Latarjet, and that's very useful. Going back to the way to, because we have been talking about indication, let's talk a little bit about how to carry out this Latarjet procedure, because you are one of the pioneers doing it arthroscopically. Do you think that people should start doing it arthroscopically from the beginning, or should they try to do open surgery when they become confident they can start doing it arthroscopically? Yeah. What should be the approach for the arthroscopic Latarjet?
I think it's arthroscopic surgery is really difficult. You need to be skilled, And I think it's like when you learn to ski. You know, you go first on the green slope, then you go on the red slopes, and then you go on the black slopes, and then maybe you can do off-piste. I mean, the arthroscopic Latarjet will always be off-piste. So you cannot go directly to off-piste. You need to progress arthroscopically to get a good level. That's the first condition. The second condition is you need a certain turnover of patients. I think that if you do, I would say, less than 30 cases of Latarjet per year, you should not try to do it under arthroscopy. You should do a good open Latarjet procedure. It's not an easy procedure open either. And I think if you do it perfectly open, and if you progressively increase your recruitment of patients, then you can start doing, for instance, the coracoid preparation under arthroscopy, and then you open, etc., etc. I think you need a transition.
I think it's very interesting your comments, because we are here in a shoulder meeting, and I had a delegate who came to me and approached me if we should start doing open Latarjet and then switch to arthroscopic, or if we should do it from the beginning arthroscopic. He was a young fellow. And I think what you said is very important. To do the arthroscopic Latarjet, you need to fulfill three criteria. First, you must think or believe that it's a useful technique, and it is. It's been proven. But so you need to feel that there's a necessity for the Latarjet. Second, you need to be experienced in arthroscopy, because it's difficult arthroscopy. So the arthroscopy is not an easy technique. And second and third, and this is very important, you should be busy enough to have at least 2 cases per month.
Yeah.
Otherwise, there's no problem. You do it open, no problem. No problem. You will treat your patients very well. You can do it open. The system works very well, either arthroscopically or open, so don't need to move and to do slightly arthroscopic. Probably when you are getting more experience, you feel the time that you feel comfortable moving to arthroscopy, and this should be the way to do it, I think. So please let me know, because you developed the OsteoConnect system for the Latarjet, arthroscopic Latarjet. It's now a long experience with it. We know your papers, publishing about it. Please let me know how do you feel with this technique. What has been your experience from the difficult first steps, because it's the difficult technique, to the results today?
So just to let you know the story, how it started. It started because of a complication. I was in the middle of a surgery doing a Latarjet open, and I had a complication. I fractured the bone block, and the piece of bone was too small to be fixed with a screw. So I had no chance to fix it with a screw. So I was there and trying to think about the solution. And I thought about the suture buttons. So I drilled through the glenoid. I put a posterior regular suture buttons at a time.
And it worked.
I put a button in the front, and I tied just by knot without any tensioning device or whatever. And of course, I was worried for the patient. So I did a CT scan at 2 weeks, 3 months, 6 months, and it healed, despite the fact that the piece of bone was very small, and only with the suture button without any extreme tension. So this is, I said, there is something there I should explore. So I started to do a series of patients with a regular suture button. And I saw
in those days you did it open?
No, and then it was under arthroscopy, because I realized that the flexibility also of the system was allow you to do more things under arthroscopy. So I started under arthroscopy. And then I followed those patients with a CT scan at 6 months. And I observed that at 6 months, I had only 65% of healing rate at the bone block. The patients were doing great, but my healing rate was still not good. And I said, I need to find something to make it better. That's where I get the idea of the suture tensioner. And I start to use this, as I was saying this morning. At first, I didn't know how much I should put as a tension on the suture. So I started with 100 Newton. And progressively, I realized you should do at least three times 100 Newton to really get the compression and remove the creeping of the suture and make sure everything is really fixed. And then my rate of healing increased to 95 or more % at 6 months, which is at least equivalent or even better than the screws. So frankly, today I'm so happy that I will never come back to the screws.
The screws.
Yeah.
That's interesting, because the screws is theoretically the gold standard for the Latarjet. It's been the traditional way to fix the fragment. When you turn to arthroscopic surgery, you need to develop new tools because it's more demanding. And there are several key steps in the technique you described using the guiding system to drill the coracoid, to use the laminar spreaders to spread the subscapularis. There are these rasp to rasp the undersurface, the abrade the undersurface of the coracoid, the saw to cut the base of the coracoid. So there are several instruments that are really helpful for this technique, which is demanding, as we said before. What for you has been the most difficult part of the surgical technique to achieve or to develop the system to be confident for the majority of surgeons?
So first of all, to let you know how the glenoid guide came from. It came from the fact that I was a knee surgeon before, so I did a lot of ACL. And of course, in the knee we were doing drilling guided. Only in the shoulder we were not guided, we were eyeballing. So, and it started with the fact that we were doing transosseous suture. At that time there was no...
I remember those days, yeah.
There was no anchor, to make a Bankart repair, we were pulling
Mulberry knot in the posterior back of the shoulder.
And this is where I started to think about the glenoid guide, to make sure, because going from the front, we didn't know where we were ending in the back of the shoulder. So I started to think to a guide for the glenoid drilling, and the main advantage of the glenoid drilling from posterior, there are two advantages. Number one, you're sure to be parallel to the glenoid. There are three. Three, you're sure that your bone block is going to be flush with the glenoid surface because this is accurate.
Yeah.
And number three, you're safe. You take no risk for the brachial plexus because since you drill from posterior to anterior and you stay inside the joint, I mean under the subscap and the capsule, there is no risk that you can pierce the brachial plexus, the neurovascular structures. So this is safe. So that's very important. It's accurate and safe. And then we had to do the same for the coracoid drilling. And I developed a guide which has 3 arms, as you know.
Yeah.
It's based on the sugar holder of my grandmother. And the reason is that I wanted to be distal enough on the coracoid, because if you're not, you see, if this is the bone block, if this is the conjoint tendon, people think that the conjoint tendon is like this with the bone block. In fact, no. The bone block is here on the glenoid, and the conjoint tendon is like pulling horizontally. So you need to put your button distal enough, otherwise your bone block, if you put it here, your bone block will stay like this. It will not be lying, it will be oblique. So that's very important, and that's the reason of the 3 arms of the glenoid guide. And actually, it's the most difficult part of the procedure, I think, is to make a perfect coracoid drilling.
That's interesting, because you have reported the importance that one drill is one button is enough. You don't need 2 buttons. I tried to use the 2 buttons, following the.
You mean 4 buttons?
No,
or two.
4 buttons, two tunnels.
2 in the front, 2 in the back.
2 in the front and 2 in the back. Yeah, correct. And you can have this problem, but because since the piece of bone is larger, sometimes you have the inferior folded subscapularis, and you have difficulty in bringing the graft in contact to the coracoid. That's the reason why, if you use a smaller piece of bone, it's easier to bring it in contact to the anterior glenoid rim. So this is true. And I have a question, which is, to me, this is trying to foresee what's going to be in the future. Because the 2 of us, have been doing the lateral arthroscopy for many years. So 2 questions about it. First, what is the future of the bone block procedures, especially the lateral in the world of shoulder surgery? This is my first question, because we know there are some differences comparing Europe to United States. Whenever we travel there, I have to stand up trying to defend the lateral, say if I were the son of lateral of Michel lateral, because they always saying that it's a difficult complication, it's a difficult operation, complications, it's not anatomical. So in the beginning I started not saying anything, but then I have to stand up, because this is what I'm doing every day. So, so I try to defend myself. This is my first question. My second question is that how do you foresee what will be the future of the arthroscopic techniques of lateral? Because we have been using this thing for quite a few years already, quite a lot of years already, and there's still not many people doing arthroscopic lateral. So how do you guess this will evolve in the future?
So I want to tell you something. I travel a lot, you know, I go to give talks, but I also go to operate in some countries. And the future of arthroscopic Latarjet is in Asia.
That's a good answer.
I've been in India.
Uh-huh.
They are very skilled surgeons, number one.
Very busy, yeah.
And they have the recruitment because the patients come late with big bony lesions, number one. Number two, since the conditions are not ideal, they don't want to open any shoulders, so they want to do everything under arthroscopy. So for sure, the future of the arthroscopic Latarjet is in Asia, in India, in China. I have a Chinese surgeon who is following me for many years and is doing the technique in China. And recently he wrote me an email and he told me, we are going to start a prospective study on your technique in China in 100 hospitals.
That's 1,000 patients, or 10,000 patients.
So I think the world will be divided in two, USA
and the
rest of the world that will do arthroscopic Latarjet because it's a needed operation.
That's interesting because I lecture all over the world as you, and when you go to US and you're talking about the arthroscopic Latarjet, you start doing what's going to be happen here, because it's always the same question. In fact, they are talking always about complications and so on, and it seems that the percentage of surgeons doing arthroscopic Latarjet over there is not increasing very fast compared to Europe and of course compared to India and China.
Yeah.
So and what about the bone block procedure? Do you think they will increase in the future, the Latarjet, open Latarjet?
Yes.
Given the evidence that is proven, that there's clear evidence that the results in terms of return to sports and so on are better compared to soft tissue procedures?
Yeah, and I think we should pay a tribute to Gilles Walsh. I mean, he's the one who has defended and promoted the Latarjet procedure against everybody.
Absolutely.
And he has reported his results very honestly, like always. And I think since all surgeons respected him, they accepted this procedure, which looks crazy at first.
Yeah.
But I mean, we should pay a tribute to Gilles for having defended this technique, and the future is bright. I mean, many surgeons, the young surgeons, the same way they have never seen an open calf repair, in 10 years from now, many of them will not have seen.
Yeah, I think so. I see my fellows, and the operation they want to see is the arthroscopic Latarjet. The fellow, they went to turn in the beginning. I remember I had a fellow, he was coming from Chile, and he was a very experienced shoulder surgeon, very well talented. He was very experienced in shoulder arthroscopy, and he came with me 1 year, and he told me, well, Emilio, I come here just to learn how to do the arthroscopic Latarjet. That was his purpose, and he's doing it now in Chile, of course.
Yeah.
Okay, so Pascal, thank you very much. It's been a pleasure. This is the episode of Joint Ventures, a sports medicine podcast for Smith+Nephew. Thank you, Pascal, for being here with us. It's been a pleasure, and thank you to the audiovisual team here. Thank you.
Thank you, Emilio.